Welcome to the components of the U.S. healthcare system, health delivery, and industry. Today we're going to talk about delineating the key definitions in the healthcare domain, differentiating between hospitals and long-term care, exploring components of healthcare delivery and healthcare systems, and discussing the importance of healthcare issues for older adults. This lecture is going to provide a high-level perspective as well as some important definitions, and I'm going to begin with defining the term health. We often think of health as the absence of disease, but that's a very narrow description. And in 1946, some representatives of 61 countries attended the International Health Conference in New York to ratify the preamble to the Constitution of the World Health Organization, which is the specialized agency of the United Nations that deals with global health. The WHO definition of health is that health is the state of complete physical, mental, and social well-being, and not merely the absence of disease. So illness represents a poor state of health, not just physical. So what else can we say about the term healthcare? It's the prevention and treatment of illness. It's delivered to people who are drawn from different and often disparate disciplines, including medicine, dentistry, nursing, laboratory science, pharmacy, any other health professions. We've got physical therapy, speech therapy. These people are all coming together in an interdisciplinary team in order to deliver care. As you can see, these people have different backgrounds and different training, but working together, they can provide complete care for a patient. We'll talk about outpatient and ambulatory care in the next lecture in part 2, but this table gives you a little bit of an example of the industry as a whole and the distribution of employment. So a lot of you have talked about health informatics and health information technology as far as a job. And here's the way healthcare is split in an industry for jobs. So when you're out there looking, the differences between offices, physician offices, hospitals, those kinds of things. And this data is from 2008, but you can see about 87% of the establishments and 42% of the employment is in ambulatory healthcare services. Ambulatory meaning walking, so usually outpatient facilities, places where people can walk into. So urgent cares like cost care that we have here, First Choice, those places, Planned Parenthood, are ambulatory areas. And about 1.3% of the establishments are hospitals, but they employ 34.6%. So they're the second largest employer, but yet they're the smallest percentage of establishments. And then, of course, you have nursing and residential care facilities. It is one of the largest industries in the U.S., and in 2008, over 14.3 million jobs were in this industry. It comprises of 595,000 establishments, and about 3/4 of these are offices. Again, we talked about ambulatory, right? So physicians, dentists, other healthcare practitioners in outpatient settings. But it's interesting to note, again, hospitals constitute a little over 1% of the establishments, but they employ almost 35% of all workers. So we talked a little bit about some of the quality in some previous readings that you had and with HIPAA and some of those. And right now, Centers for Medicaid and Medicare Services and the Joint Commission are those individuals, very important to know about, that provide the health insurance and also the quality and safety measures for organizations. If quality measures are not met, and there's a failure to report, a facility can lose their license and not be able to practice. Now, this affects our area here in Montana a lot because our hospitals, particularly one of the hospitals in our area, is called a disproportionate share hospital, which means more than 51% of all reimbursement comes from Medicare, Medicaid services. And so if we were to fail meeting the qualifications for CMS and the quality and safety measures set in place by Joint Commission, then that hospital would not be able to stay afloat because they would not be able to receive reimbursement, and that would be more than 51% of their income. So they'd be operating at half the income or less. CMS and Joint Commission are responsible for defining quality measures, enforcing those quality measures, and there is reporting that is mandated by both agencies. So here's some other independent healthcare providers, are single provider practices or group practices. Things like Missoula Bone and Joint that you might be familiar with here in town is a group practice. A single provider practice would be if you go and there's one physician there and his or her one office. Corporate healthcare is places, you've heard a lot about this in the news lately, where Kaiser Permanente was one of those types of facilities where generally in large cities where they have large industries, there is a healthcare facility just for those employees. A lot of the mines here in Montana at one time owned and ran the hospitals for the miners, and that's a corporate healthcare. And then there's community agencies, and then we have for-profit and not-for-profit status. It can be delivered in different places, and we're going to talk about hospitals, and I promise it'll get a little bit more interesting. But they're institutions for treating sick and injured people, obviously. They've historically been places for shelter or almhouses. When we think of inpatient facilities, we typically think of these hospitals. They're a physical structure. It houses patients during treatment. It allows clinicians to conduct diagnostic tests and perform management, interventions, and specialized functions such as surgery or managing childbirth. The Hospital Survey and Construction Act, passed in 1946, provided federal grants to improve these physical infrastructures of hospitals. Again, hospitals can be profit or non-for-profit. They can be government supported. They can be general or specialty. So if you think of like the Cancer Institutes of America, those are a specialty hospital. Children's hospitals out in Seattle, at Seattle Children's is a specialty hospital. Be university affiliated or community based. They can be single or in a chain. So you have like the Sisters of Providence is like a chain of hospitals owned by an organization or run by one entity. Critical access hospitals, they get Medicaid reimbursement and some special rules financially along with those terms if you are a critical access hospital. There's long-term hospitals, psych hospitals, day hospitals. University of Washington Medical Center would be an example of the university-affiliated ones. Marcus Daly in Hamilton is considered a critical access hospital. And then we talked again about one of the hospitals here in town, Community, is a disproportionate share hospital. So Pennsylvania Hospital, and this is where I'm from. I'm from Pennsylvania, so I love this little picture here. It was founded in 1751 by Dr. Thomas Bond and Benjamin Franklin, and it was to care for the sick, poor, and insane who were wandering the streets of Philadelphia. Hospitals have over 25,000 admissions each year, including 4,200 births at this particular hospital. And it is part of the University of Pennsylvania health system, which makes it part of one of those university hospitals that we just saw on the other slide. Healthcare encompasses infrastructure, technology, the providers, and the patients. There is more to a hospital than just the place you go to get better. In health information technology, we augment these areas, starting with the infrastructure. So in IT, we have to assess, if you look at this building, we are looking at all of that infrastructure. How are we going to pull cables? Where's the server room going to be located? How are we going to apply our wireless access points, and how is that affected by lead rooms? A lot of these buildings, being older, have really super thick concrete walls, some of them underground. They can have lead or other types of material they were made out of that can block signals. So when it comes to wireless, we have to think a lot of that. Where are the water pipes located? You don't want to put your server room under the boiler room. That's not a smart thing to do. So here's just some fun pictures. We've got all of this different, I keep talking about this infrastructure technology, and here's what the lab used to look like back in the 20s. And if you look, it looks like something from Chemistry 101. You've got beakers and Bunsen burners, open flames. This was how they were testing patients' specimens. And we don't do that. We use chemical analyzers today. Here's an example of an EKG machine, and it's kind of hard to see, but the paper that's scrolling out over there on the far right-hand side is the actual heart tracing. Look how huge this is. This is the size of a large, computer, and for its time, where would you put this in a patient's room? So it's something that you need to think about when it comes to the technology. Where would you place this? It would have to be close to the patient, or they wouldn't be able to hook the patient up. But where are you going to put that in a hospital room? If you haven't been in some rooms lately, you should see there's not a lot of room left. And here's a surgical suite, and you can notice over there on the far right-hand upper corner, you can see the tiles. This is a basement, solid brick wall, and they're operating underneath this half glass wall that's coming down. And look at all the different pieces of equipment. They've got oxygen tanks over there by the circa 1980s labeling on this screen. And how would you pull wires through these concrete walls or around this tile? And all the different people. You've got the patient, you've got the lights, you've got the people, and the people need to be able to move around in this area, as well as where do you put the monitors and where do you put them in a room like this so that everybody can see what's going on. So now switching gears a little bit from acute facilities, which is what a hospital would be, is to these long-term care facilities. And as the population ages, individuals take longer to recover, and it's not very cost effective to put them in an acute hospital setting. Average cost of an ICU stay, so just the room and board for being an ICU patient in the hospital is somewhere between $1,100 and $1,500 in our area here today. It's much more if you go to some of those specialized areas. So they need to be in a facility that's cost effective and that can specialize in activities of daily living, or ADLs, activities of daily living. Ding, ding, ding. Remember that one? Activities of daily living are those things that you need to be able to do every day. Bathing, dressing, combing your hair, brushing your teeth, being able to feed yourself. Other services at these long-term care facilities are group and social oriented. So it provides some kind of activities to stimulate their thinking processes, to keep them entertained. And medical facilities that are have on-site personal intimate care needs that are related to a medical condition, and that's what the care needs would talk about. So if there are some times where they still are able to get IV medications or some diagnostics or some additional specialized care other than just like a group home with living. And as the ADL, or activities of daily living, needs increase, it's going to happen across the U.S. You keep hearing things about baby boomers, and we've reached that baby boomer time in America. But look at the types of ADLs, and you can just see as you age how they increase. And that was the point of this graph, is you've got the percentage of adults, and then that yellow bar is 85 and older, and people are historically living longer. And so every 10 years, basically, that need for help with the things that you and I do every day and take for granted, using the toilet, for instance, is more than doubling. So there's a great need for this type of care. Home health care. So long-term care is usually a physical structure, Riverside Nursing Home, Hillside Nursing Home here in the area, where a person stays and gets help with those things, whether it's during a rehabilitative state or whether this will be their permanent home for their final days. Home health care allows for individuals to come in and do chores inside the home, and there is money that can be reimbursed by Medicare. Oftentimes you have to really prove the need, or it's only for skilled tasks. So it used to be back in the day, if a person needed help with bathing, that was considered skilled, and so it would pay for an hour a day or an hour and a half a day in order to get a person bathed. And so to maximize those kinds of things, they usually try to do the bath time at breakfast time or the bath time, say at lunchtime, so that whoever the person was, the home health care aide or the home health care nurse that was coming in to do that activity with the patient, could also double up and perhaps make their breakfast or lunch as well, because that's the only way these people could get reimbursed and afford to have somebody come into the home. Board homes and group homes, these are group living arrangements that for people who can't live alone or need help with ADLs. Sometimes it's because they have mental or physical impairments. They may or may not be elderly. This is a key point here. Oftentimes these are young adults. They could even be younger children that the parents just cannot manage their care within the house because they need 100% supervision all the time, and sometimes it's specialized. But it ranges the gamut. It could be individuals that they can get out and they can actually hold jobs, but maybe because they have seizure disorders or something, they just can't drive, and maybe they're a little bit less socially capable, and so they can hold a job, and maybe they can feed themselves, and maybe they can make their dinner if it's in a microwave, but they're not the kind of person that you'd say you'd want them left alone with open flame or a barbecue or something. There's just some things they can't quite do. And so these group homes try to foster independence, but also provide some assistance as needed to help these people be as independent as possible. And assisted living is a little bit, if we go back to this board care and group homes, generally there's more independence here. The assisted living generally needs more help, and there's more group and social activities that are planned for these people. Generally, there's more medical services that are available. They do need to be licensed, but again, the person usually has their own room with the staff that's in there. Retirement communities offer even more greater independence. Usually, they live separately. There may be things on site to help, like a physical therapist may have a room, and so if somebody just needs more like exercise, there's areas with that. Sometimes it's easier for them to have a home health care aide because potentially the home health care aide is a hiree of the retirement community, and so instead of trying to find a different person or a separate agency to come into each one of these homes as needed, you have an employee of the community that whose job it is to know the residents and come in and out of their homes as needed. So it's a little easier for scheduling and things, and more dependable. They do not need to be accredited, but they could be. And usually there is a substantial entry fee, and then there's monthly payments, which is different than some of the other sites. Then nursing homes come in under that long-term care of the physical building structure we were talking about. And like a hospital with less care, there's usually medical and nursing care on site. Some are hospital-like and others are more home-like, meaning that they have like a kitchen or more social activities that allow the person to, say, go out and garden, or a person could potentially cook their own food, but usually it's with supervision. This requires a plan of care to be drawn up by a physician, and nursing care is generally for routine medications, any rehabilitation, and potentially acute conditions, such as a dementia or Alzheimer's unit. And then we have just some other long-term, we call them long-term care options, but those would be any community-based services, Meals on Wheels, senior centers that do things, There's in-law apartments, which are separate living spaces that are on someone's property. So your parents could live in their own place, but basically they've got you to check on them all the time. Subsidized housing, so you might live independently, but because of retirement or your Social Security isn't enough to cover rent. If you think about what you all might be paying in rent here in Missoula, an elderly person may not be able to afford it, so there are subsidized housing programs. And so again, it's considered part of long-term care because it's things these people are going to have to, it's the remainder of their life, forever. Hospice is unique. Hospice is intended for patients with a terminal illness. Generally, you have to have a diagnosis of 6 months or less to live. And its focus is not on getting you well, but making you comfortable. And the word for that is palliative care. You'll hear that a lot. It's generally done in the person's home. It's at their request that they want to be in an environment that's familiar to them, where they're comfortable. But hospice can come into play in areas of like nursing homes or other assisted living facilities. It can happen anywhere. And there's Hilda's Room, a community medical center, which you can have hospice come in. So sometimes to get into Hilda's Room generally would be the case where you would be presented to the ER maybe with a severe stroke. So you're still alive, but you're not going to recover, and it's pretty evident. And then you can be in Hilda's Room, and they usually reserve that if they've got just a couple of days to live, versus if you've got weeks or months. And the big thing about this is with the comfort care is also generally maintaining contact with a family. It's allowing them to have time to grieve and come in and say goodbye. And those kinds of services. It also includes what's really great about hospice as like a theory of hospice is when we talked about all that interdisciplinary care earlier on in these slides, and we talked about all the different teams from different disciplines, physical therapy, nursing. This includes pastoral and social services, and it's all of these disciplines coming together to help not only the patient, but the family as a whole go through this grieving process, come to terms with what's going on, make sure that other services in the community are made available. Some of you may or may not have ever heard of the Chalice of Repose, which has nothing to do necessarily with the medical world, but it was persons who were gifted in music, and generally it was a harp, because that's a very soothing sound, to come in and would play for a few hours for a patient, and just they say, music calms the beast or whatever, and that's what the Chalice of Repose did. It provided a relaxing atmosphere and just to help calm people in these situations. There are a lot of legal and ethical issues, particularly around hospice. But as a whole, anytime you're trying to get somebody into a nursing home or into a group home or assisted living facilities, many times these people were very independent at some point in their life, and now you're getting to a place where you're trying to, tell dad he can't drive anymore, and it creates anger, and it can be very difficult. And so this is at a time where patients may or may not be able to make decisions for themselves. They may not have the cognitive capacity to make them. And if they had dementia, or if they had a serious head injury, or it may be because they physically can't express what some of those decisions may be in some form. And we're going to hear a lot more about patient-centric modeling, I hope, throughout these discussions. And patient-centric is where we're going at with the electronic medical record being a patient-centric, where we're going with healthcare as a whole being patient-centric, and that's putting the patient in the center, patient-centric. And that patient being at the center of the care means that all things should be for the patient, and the patient should be the focus of what's going on. and that they do have rights regardless sometimes of their mental or physical capacity. We have things like legal guardians. You may need a power of attorney for health care. It is at a point where you need to make these discussions about taking dad's car keys away, and if he needs other long-term care options or Meals on Wheels, how you get informed consents and informed refusals. We've got advanced directives, something called PULSed, which is a combination of a hospital do not resuscitate and what we refer to as a comfort one. And I'm going to stop right there because I work in emergency medicine, and it's something I want to make sure everybody understands. If you come into a hospital, your physician will have signed for you, if you have a terminal illness or at your request, a do not resuscitate order or a DNR. That is only good in the hospital setting. If you are terminally ill, or if you know anyone who's terminally ill or has made life choices in their home, when an ambulance arrives, an ambulance does not operate under a do not resuscitate. That's for a hospital only. You need to have a comfort one, and it needs to be clearly posted somewhere or where a family member knows where it is. So it's something I struggle with, because I will show up on scene with somebody who is elderly or is known to have a medical condition or terminal illness, and they're dying, and I've had to perform CPR on them. Even though the family says that there is a do not resuscitate, legally I am bound to act on that patient's behalf unless they have this comfort one. The PULSed is something that was new to the state of Montana that is a combination. So what it does is it's the piece of paper that provides both. The physician has signed off as a do not resuscitate, and it has this comfort one component. And if somebody has a PULSed, then the ambulance service or the first responders can act accordingly. And that does work both inside and outside the hospital. When it relates to HIPAA for ethical legal obligations, all long-term care facilities that we've talked about have all the same obligations as an acute care facility. When it comes to HIPAA, they've got security, confidentiality, quality, and fiscal. And health information technology is where we can provide security. It's where we can provide the data reporting and collection, or data collection and reporting that these facilities may need. It also allows for the continuity of care or continuum of care, because as information technology personnel, we should be able to program the system so that the data can go from place to place to place. So if a person is in a long-term care facility and needs to go to an acute care like a hospital and then back from the hospital into a long-term care, that information should be able to be available so that their care is seamless between those different places in a patient-centric model. So in summary, health is not the absence of disease. There are many types of facilities and organizations that can deliver health care, not just hospitals. Healthcare delivery encompasses infrastructure, technology, healthcare workers, and patients, all of it together. Healthcare delivery funding comes from many sources: Medicare, Medicaid services, private pay insurance, from a person's own checking account. The need for elder care is growing. Remember, every 10 years, the need for those ADL assistance is doubling. Complex financial, legal, and ethical issues apply, whether it's obligations, legal and from a Joint Commission, Centers of Medicaid, Medicare Services issues, complex financial as it relates to making sure that facilities are following the regulatory requirements so that they can be reimbursed, to ethical issues about making those decisions and the difficulties of making those decisions with our loved ones and being sure that we can make them legally and help them make those choices as they come to terms with their end of life. Health information technology faces many challenges, but we also have many opportunities and many opportunities for employment as well as opportunities to make things better and more efficient in this healthcare delivery.